Hi dear students, so this is a NEET PG 2024 recall session by Manipal Medes in the subject of general medicine. I'm your faculty Dr. Akshay Rao. The purpose of this session is dual. One is to try and help those students who appeared for the exam just yesterday, it got concluded yesterday, to try and help them to assess themselves how they may have performed in their respective exams. And it's also meant for perhaps future audiences who may be watching it towards their next year's exam, perhaps as it is approaching. They want to know what was asked in the previous years with regards to general medicine, so they want to quickly look at what were the questions, what could have been the answers, and what were the other possibilities or the options. So this session will also serve them. So with that in mind, we've tried to keep it as brief as possible. We don't want to take up any of your precious times. And do remember, in case you feel there are some questions that are not here in general medicine, that's probably because there's a lot of overlap that happened during yesterday's both sessions. There were two sessions, of course. There was shift 1 and shift 2. And because of that overlap, we have decided here at Manipal Medis to try and segregate the questions in such a way that if a particular question is felt to be more important from pharmacology point of view or radiology point of view, the respective faculty will be dealing with them. So in case you feel some question got missed out in this recall, you'll probably find it in the recall sessions by, let's say, pharmacology Arpit sir or Abhishek sir in radiology, and so on. Okay. And of course, just a word on the exam itself. The students did find it to be slightly difficult. Perhaps that was because a lot of integrated questions appeared, a lot of multiple subjects were inculcated or incorporated into a particular question, and not so much of scenario based question, or at least those scenarios were not very difficult, is what I personally feel. But maybe a little bit of difficulty faced because of lengthy questions, lengthy stem of the question, and incorporation of multiple images. So, but nonetheless, I hope all of you have done well. And with that in mind, especially because this year's NEET also there was drama. Initially, it was scheduled to be held in June, and then at the last minute, it got postponed, almost literally last minute. So finally, it's over, and let us try and dig deep into the medicine-based questions. There were two sessions, like I told you. I've not kept them session-wise. I've just taken all the questions that we could collect from different students who had appeared for the exam, and we'll discuss it as short fashion as possible. So the first question. Patient has progressive fatigue, pedal edema is noted, JVP is elevated, and the Y descent in the JVP is exaggerated. That means there's a rapid Y descent. So what could the diagnosis be? So this itself is enough to try and help localize or to narrow down the differential diagnosis. And of course, the options were chronic constrictive pericarditis, cardiac tamponade, congestive cardiac failure, and pulmonary edema. So among these options, obviously, the only condition which has a rapid Y descent is chronic constrictive pericarditis. And this is corroborated with the additional history suggestive of right-sided heart failure, pedal edema, progressive fatigue, as well as elevated JVP. So if the options also had tricuspid regurgitation, then perhaps it could have been a little more difficult to narrow down the answers. But among these, because tricuspid regurgitation also has a rapid Y descent, but in case of CCP, constrictive pericarditis or chronic constrictive pericarditis, both X and Y descents are quite prominent, and that is what has been mentioned here, as we've discussed repeatedly. So JVP-based questions are very frequently asked. ECG-based questions are very frequently asked, both in INI and NEET. So please do revise these whenever you try and are trying to prepare for these entrances. Okay, so clear-cut chronic constrictive pericarditis, a number of questions are possible. Very, very important topic. CCP is a very, very important topic. Differentiating it from cardiac tamponade is very, very important. Of course, chronic constrictive pericarditis, as the name suggests, is chronic. Cardiac tamponade is an acute event. Even though the etiology might be slowly progressive, the actual event of cardiac tamponade is an acute event. Okay, moving on to the next question. Match the following arrhythmias. This was a question where 4 arrhythmias, the names of the arrhythmias were mentioned, and the options had, or the other table had the actual images, the ECG images of those arrhythmias. And as I told you, ECGs are very, very important. CBME itself mandates that you'll be aware of how to interpret an ECG, how to perform an ECG. And likewise, even the entrance exams do ask questions. So options given were atrial flutter, atrial fibrillation, PSVT, and ventricular tachycardia. or other ventricular fibrillation. So this was a slight discrepancy. Some students said ventricular fibrillation, some said ventricular tachycardia. So it all depends. If the ECG complexes contained QRSs which were broad, so QRS which is broad or wide, how broad? More than 120 milliseconds. So if it was more than 120 milliseconds and there was tachycardia, that means heart rate of greater than 100, then in that case you could have considered it to be ventricular tachycardia. Instead, if you found very haphazard complexes, you didn't see any P wave, you couldn't make out any QRS also, just haphazard complexes like this. Okay, this is what is suggestive of a ventricular fibrillation. So some students felt it was ventricular fibrillation in the options, some said ventricular tachycardia. Probably it was ventricular tachycardia, but nonetheless, the other options were quite clear: atrial flutter, fibrillation, and PSVT. We've discussed this multiple times. Whenever you see in your entrance exams, whenever you see broad-based or broad QRS complex tachycardia, so wide complex tachycardia, wide QRS tachycardia is only and only ventricular tachycardia. Okay, VTAC. So please remember, anytime you come across broad complex tachycardia, it has to be ventricular tachycardia. It's very unlikely that they'll ask you anything else apart from ventricular tachycardia. You can get PSVT with aberrancies as broad or wide QRS complex tachycardias, but you're very unlikely that they'll ask you this. Okay, instead, if there is a wide complex tachycardia, wide QRS tachycardia, always think of ventricular tachycardia. Okay, and with regards to irregular rhythm, if you don't see P waves, so P waves are absent, and if you get irregular rhythm, always think of atrial fibrillation. So atrial fibrillation is an exam favorite. Every exam, every INI, every NEET has questions based on atrial fibrillation. This was no different. There was a JVP based question also in atrial fibrillation, as well as this ECG question where it was involved in the match the following aspect. Okay, so irregular rhythm with P waves absent goes in favor of atrial fibrillation, right? So atrial fibrillation is a condition with P wave absent in ECG and A wave absent in JVP. Both got asked. Okay, both were asked. Both aspects of atrial fibrillation were asked in this NEET 2024. And the next condition was PSVT. PSVT is a narrow complex regular tachycardia. So remember, narrow QRS and regular tachycardia. You may or may not be able to make out the P wave, but your best bet that if you see an ECG with narrow QRS complexes and regular tachycardia, you have to mark it down as PSVT. Okay, so anytime you saw an ECG where it was a regular rhythm with QRSs being narrow, you have to think of, and the rate being high, you have to think of PSVT. Okay, and finally atrial flutter. Flutter is not so difficult to make out and relatively benign rhythm. Of course, a lot of other questions can be asked based on all of these arrhythmias. Atrial flutter is the most common arrhythmia that occurs post cardiac surgery. And how do you make out? You see these P waves. These are flutter waves or F waves. They called F waves also. You can see the P waves coming so fast, so rapidly. So number of multiple P waves, but not all of them are getting conducted. Eventually, when one does get conducted, it will produce a QRS which is not broad. So narrow QRS complex, which is interspersed between several or multiple P waves. So this kind of a pattern, which has multiple P waves evident, instead of an isoelectric baseline, it's just P wave after P wave, and then finally gets conducted, produces a QRS which is narrow. This is called atrial flutter, most common after cardiac surgeries. PSVT, they could always ask questions based on how do you deal with it. If a patient is hemodynamically stable, that involves carotid sinus massage or giving adenosine. If the patient is unstable, always go for electrical cardioversion or defibrillation. Okay. Defibrillation is of course not meant for PSVT. Cardioversion for if the patient has a pulse, if a patient has an arrhythmia and has a pulse, it's always cardioversion. Okay, whereas if a patient, that means it's synchronous DC shock. Whereas if a patient does not have a pulse and the patient has had a cardiac arrest, then it is defibrillation. Okay, so next question was on drug reducing mortality in heart failure. This is something that has been repeatedly emphasized by myself in the app, in the videos, saying this can be a potential question, and it did get asked. So hopefully all of you were aware of the answers and were able to mark it correctly. So the options given were all beta blockers. So basically they wanted to ask which beta blockers have cardiac mortality benefit, which one will be most useful in patients of heart failure. So basically they have anti-remodeling properties. Now among the options, bisoprolol, labetalol, propranolol, and pindolol, the only option which would be correct is bisoprolol. So remember, the drugs with cardiac mortality benefit. This is how I had taught. This is how the question has come. I've even mentioned that it's a potential question. That's what's happened. So carvedilol, metoprolol, and bisoprolol. These are the only three beta blockers. That too, metoprolol succinate. Okay, not even metoprolol tartarate. So carvedilol, metoprolol succinate, and bisoprolol. These are the anti-remodeling agents among the beta blocker classes. These are the only beta blockers which have cardiac mortality benefit in heart failure. Okay, labetalol is a combined alpha and beta blocker, does not have. Propranolol is a non-selective beta blocker, does not have. Neither does pindolol. Okay, and this apart from the other classes of medications which have mortality benefit, that would include any inhibitor of RAS, SGLT2 inhibitors, and the combination of isosorbate dinitrate and hydralazine. So these are the few drugs with cardiac mortality benefit in heart failure. Next, what occurs in stage 3 of type 1 diabetes? So this is a slight bouncer. This is a newer concept, and that you needed to be aware of. And why it's more in prominence right now is because of the drug teplizumab. So teplizumab is an anti-CD3 monoclonal antibody which can be given in patients of type 1 diabetes who are in stage 2. Okay, and therefore prevent their progression into frank diabetes. So which means stage 2 is also not yet frank diabetes. But going over what are stage 1, 2 and 3 in type 1 diabetes. Stage 1 is when they have autoantibodies, 2 or more autoantibodies. The typical autoantibodies in type 1 diabetes, GAD65, and along with that either ICA 512 or zinc transporter 8. These typical autoantibodies, at least 2 should be present along with normal blood glucose level. So somehow perhaps the patient had another autoimmune disease, and then this panel was sent, this panel of autoantibodies for type 1 diabetes was sent, and you discovered that it is positive. If the blood glucose is normal, that is stage 1. Stage 2 is such patients with autoantibody positivity going into dysglycemia. Dysglycemia means it's still impaired glucose tolerance or impaired fasting glucose. So basically they still don't have hyperglycemia. Obviously they don't have symptoms also. And in type 1 diabetes, the moment they have hyperglycemia, they will have symptoms. Correct? So this is more of an intermediate stage. It's like the pre-diabetic stage of type 2 diabetes. Likewise, this stage 2 is a pre-diabetic stage. This is where you can give that teplizumab, and that is why this question has probably been asked. Okay, stage 3 is what they have asked, and that is the stage of hyperglycemia where symptoms also start. They still have the autoantibody profile positivity. Okay, so the answer to this question, where stage 3 of type 1 diabetes mellitus is hyperglycemia with 2 or more autoantibodies positive. Okay, so that was the answer to this question. Next question, pleural effusion with the pleural fluid protein, pleural fluid to serum protein ratio of more than 0.5, which is by itself significant. So just one of this should have been enough for us to say, yes, this patient has an exudative pleural fluid or pleural effusion. But along with that, they've even given LDH being, the ratio of the pleural fluid to serum LDH being more than 0.6. So both these would qualify or rather would satisfy the Light's criteria. So patient has Light's criteria being satisfied. Obviously, you have to look for only exudative causes. So they have asked among these options, try and make out what is the exudative cause of pleural effusion. So obviously, nephrotic syndrome, liver cirrhosis, and congestive cardiac failure, they are causes of transudative pleural effusion. Tuberculosis, the most common cause of exudative pleural effusion in India, especially because it's a chronic infection. Although pneumonic effusions, overall worldwide pneumonic effusions are more common, but in India, tubercular pleural effusion has to be the most common cause of exudative pleural effusion. So among these 4 options, only tuberculosis would qualify as an exudative cause of pleural effusion. So this also was quite straightforward. Hopefully all of you got it right. Next, a 50-year-old patient came to OPD with angina and dyspnea. So what was the explanation for the angina? I suppose this is how the wordings might be a little different, but what may have been asked is, if a patient has angina and dyspnea and is found to have AS, aortic stenosis. So that was also mentioned, I think. Aortic stenosis was mentioned. How do you explain this patient's angina? Or what is the true statement regarding angina and in aortic stenosis? So obviously, aortic stenosis, angina is the first symptom that is attributable to aortic stenosis. Severe aortic stenosis, severe and chronic aortic stenosis, they will end up developing angina. Angina will be the first symptom. This will be followed by exertional angina, exertional syncope, and exertional dyspnea, finally landing in heart failure. And all these they come in a serial order, and they give a rough, if they are not treated, they give a rough idea of how long the patients will survive once the symptoms appear. So exertional angina is 3 to 5 years. So once they develop, patients of AS develop angina, they may not be expected to live beyond 3 to 5 years unless that aortic stenosis is corrected surgically. Okay, so now what the question was is options. Pressure overload causes the increase in oxygen, myocardial oxygen demand. Obviously, this is correct. So because in aortic stenosis, there is a stenosis valve against which the left ventricle has to pump harder than usual. Therefore, if it has to overcome that obstruction, it has to try and hypertrophy. So left ventricle hypertrophies, and this kind of a hypertrophy, it's called concentric hypertrophy. That concentric hypertrophy is not good for the myocardial oxygen demand. More muscles, more work, demands more of blood, and obviously the coronaries may not be able to supply the increased demand, and therefore they may end up developing angina. Okay, and remember, in such patients, nitrates are, you cannot give them nitrates. If you give them nitrates for their angina, it can be a disaster, because nitrates will end up leading to peripheral vasodilatation, and that will not be good for patients with aortic stenosis. And the other options were quite obviously wrong. Workload has nothing to do with oxygen consumption. No, whenever the myocardium has to work more, it will require more oxygen. Therefore, our aim has to be try and reduce that oxygen demand. Aortic stenosis reduces pressure at the aortic valve. No, it increases the pressure at the aortic valve. There is going to be stenosis. An increase in preload more than afterload, not in aortic stenosis. Okay, so in aortic stenosis is always going to be more increase in the afterload. Okay, I think there were some students who mentioned that there was a mention of aortic stenosis and aortic regurgitation. So patient has AR and AS, and that's why the person had angina. You had to try and make out whether the angina was because of AR or because of AS. Okay, but obviously if the AS is greater, then the angina has got to be because of increased afterload and leading to myocardial hypertrophy and increased oxygen demand. So answer for this was increased pressure overload leading to increased oxygen demands. Next question, 18-year-old boy presented with fever, pain in the knee joints. Auscultation revealed a pansystolic murmur in the mitral area. What is the diagnosis? And the options given were rheumatoid arthritis, rheumatic fever, seronegative RA, and ankylosing spondylitis. Now the first point to look at is the age of the individual. So age itself goes against, and the sex of the patient. Age and sex go against rheumatoid arthritis, even seronegative. You wouldn't expect such a young boy to develop rheumatoid arthritis. So the options come down to ankylosing spondylitis, which can occur at such a young age, and acute rheumatic fever. Now question is which joints were involved. So fever and pain could be seen in both, but not so common, although fever is not so common in ankylosing spondylitis, but it's possible. But knee joints being affected and no mention of the back pain or involvement of the intervertebral joints, that means ankylosing spondylitis becomes unlikely. So options up till now, this much information would best suit acute rheumatic fever. Reading on, auscultation revealed a pansystolic murmur in the mitral area. This is definitely going to favor diagnosis of acute rheumatic fever. So acute rheumatic fever patients will have development of pansystolic murmur due to mitral regurgitation. So initially there's going to be MR, then finally later on there's going to be stenosis of the valve. So MS is a late manifestation. Acute rheumatic fever, during acute rheumatic fever itself, they can have a mitral regurgitation. Okay, although you get a mid-diastolic murmur of Carey-Combe murmur, that is not consistent with mitral regurgitation. That is mainly because of the valve having roughened up. Because the valve has become, the surface of the valve has become rough, the movement of blood across that valve may produce a mid-diastolic murmur. It's not because of mitral stenosis. Instead, earliest manifestation in terms of valve abnormalities in acute rheumatic fever is mitral regurgitation. Only later on it will lead to mitral stenosis. So pansystolic murmur is consistent with mitral regurgitation, which definitely occurs in acute rheumatic fever, not in ankylosing spondylitis, which leads to aortic regurgitation due to root dilatation. Same way, even rheumatoid arthritis leads to aortic regurgitation due to root dilatation. But the most common valve abnormality, if you are asked what is the most common valve abnormality in rheumatoid arthritis, it is mitral regurgitation. So don't be surprised if a patient of rheumatoid arthritis develops mitral regurgitation. That is the most common lesion, valve lesion in rheumatoid arthritis. But in terms of joint involvement, rheumatoid arthritis and rheumatic fever or acute rheumatic fever joint involvement, totally opposite. Rheumatoid arthritis, it is symmetric, it involves the smaller joints, and it can be erosive, leads to deformities in the future. Okay, and it's chronic, it's persistent and chronic unless you treat it. Whereas in acute rheumatic fever, it's going to involve the larger joints like the knee, and it's not going to be symmetric. It in fact is migratory. So migratory polyarthritis involving the large joints, non-erosive, usually does not lead to deformities. may lead to something called Jacquard deformities or Jacquard arthropathy, but not common. And usually it will resolve. Okay, acute rheumatic fever licks the joint, bites the heart. It will resolve once the episode of acute rheumatic fever has subsided, maximum 12 weeks. So answer to this question would be acute rheumatic fever. Right, next question, patient with irregular pulse, and the question was which waveform of JVP is absent. I'm sorry, this is supposed to be is absent. Okay, yeah, the option itself mentions it. So what will you see? What abnormality will you see in the JVP? Will you see Canon A waves? Will you see absent A waves, or rapid X descent, or slow Y descent? So obviously irregular pulse, the first thought goes towards atrial fibrillation. Any additional mention, the students could not recollect whether there was any mention of pulse deficit being greater than 10, or let's say if the patient had either ECG was given where the P wave was absent, or perhaps even mention of a variable first heart sound. Any of this additional information would have sealed the answer. But at least an irregular pulse, what you usually end up associating it with is atrial fibrillation. So atrial fibrillation, what happens to JVP? Absent A waves. A waves are because of atrial contraction. The atrial only fibrillating, they're not going to be producing any A waves. There's not going to be a rise in right atrial pressure. So answer, if a patient has irregular pulse, what change do you expect in the JVP? Absent A waves. Okay, Canon A waves seen in patients with tricuspid stenosis. Slow Y descent also seen in tricuspid stenosis. Canon A waves, you can also get it in third degree AV block. And rapid X descent is something you can see in patients of cardiac tamponade. You can also see a prominent X descent even in constrictive pericarditis, but cardiac tamponade is classically associated with very rapid X descent. Okay, so obviously these answers are, the answer to that question would happen to be absent A waves in atrial fibrillation. Next question, patient has chest pain, hemodynamically stable, right atrial collapse seen in diastole, X-ray shows below. Next step. So I think the X-ray contained cardiomegaly with a clear lung field. So cardiomegaly plus clear lung fields would indicate the possibility of pericardial effusion. So pericardial effusion. So if this patient has a pericardial effusion, this is what the students said. There was an X-ray which showed pericardial effusion. The cardia was enlarged. There was cardiomegaly, but the lungs were quite clear. Okay, so that means it's not heart failure. If the lungs were also, bronchovascular markings were prominent, the perihilar veins were prominent, upper lobe veins were prominent, you could have thought of heart failure. But if it's a cardiomegaly, which is looking like a water bottle shaped heart, so water bottle shaped heart, this goes in favor of pericardial effusion. And now in a patient with pericardial effusion, has chest pain, hemodynamically stable, but has right atrial collapse seen in diastole. So which condition would you see the right atrium collapsing in diastole? So when the ventricle is relaxing, the atrium is supposed to allow blood to flow from the right atrium into the right ventricle. But in case during the right ventricular diastole, the right atrium is totally collapsing, and that means the blood from the veins, great veins, systemic veins, if it has to enter the right atrium, it can't be happening in this condition during diastole. It has to enter only during the systole. So when the right ventricle is contracting, that will be the only time where the right atrium can receive some blood from the systemic veins. So which condition does that happen? That means the venous inflow into the heart occurring only during systole, ventricular systole. This can occur only in patients with cardiac tamponade. So indirectly they told you this is a condition with cardiac tamponade. Patient has cardiac tamponade, though hemodynamically stable. Blood pressures may be fine, but then the patient has cardiac tamponade. So what do you do in such patients? How do you treat such patients? So do you give them diuretics? Absolutely not. That will be disaster. Any patient with cardiac tamponade, first thing you do is give them a lot of fluids. Give them IV fluids. Maintain the chamber dimensions. Don't allow it to collapse. NSAIDs, they're not going to act anytime soon. Steroids, neither. So you can't really expect dramatic changes by giving them NSAIDs or steroids, even if there is an underlying inflammatory cause. So inflammatory causes suggested by the presence of chest pain. So if they have pericarditis type of chest pain, which it's a retrosternal pain, gets referred to the trapezius, gets worse on lying down, relieved on sitting up. These features suggest pericarditis type of chest pain. The moment there is pericarditis, there's inflammation, there could be anti-inflammatory drugs that can be used. But that is not for in a patient who has now gone to the stage of impending cardiac tamponade. The diastolic collapse of the right atrium suggests that the patient is going to go into cardiac tamponade. So therefore, these become wrong options. Instead, pericardiocentosis is imminent, or rather it's urgent pericardiocentosis for imminent cardiac tamponade. That would be the answer if the question was like this. Okay, next question. What is the best investigation for Wilson's disease? If the term used was best investigation, then obviously the best answer is you have to see the liver, you have to quantify the liver copper content. So unless you see the copper yourselves or quantify the copper within the liver, you can't be 100% sure. So best investigation is to check for the copper content in the liver, that is through a liver biopsy. It has to exceed 250 microgram per gram of liver tissue, dry weight liver tissue. So unless you can quantify it, you can't be 100% sure that the patient has Wilson's disease. Urinary copper, maybe it is definitely going to be increased in Wilson's disease, but not so specific. You can't really attribute it to Wilson's disease. Okay, actually, if there was any mention of genetic analysis, it would have been even better. Genetic analysis would have given an even better answer, but since that was not in the options, the next best option is hepatic iron content, or rather hepatic copper content. It was not a question of iron, that's why MRI of liver is ruled out. Serum ceruloplasmin can be low in any patient with cirrhosis. Ceruloplasmin is produced in the liver. If there is liver cirrhosis, whether it's Wilson's disease, hemochromatosis, hepatitis C, anything that produces cirrhosis can lead to low ceruloplasmins. It's a good screening test. If it is like negative, you can't really expect patient to have Wilson's disease. If it is positive, you can go forward for confirmation. Confirmation has to be practically using biopsy of the liver. Right. Next question. A lady presented to the OPD with nasal obstruction and recurrent respiratory infections. This itself gives you a clue. So which are the conditions which produce recurrent respiratory infections? Obviously structural lung diseases, which means bronchiectasis is a big possibility. Now X-ray showed situs inversus. I have not put up the X-ray, but X-ray showed that the heart was shifting towards the right. It was seen towards the right of the mediastinum. So it was right of the midline. So obviously when the heart is on the right side of the thorax, you have to suspect the patient has situs inversus. So situs inversus, bronchiectasis, the only thing that comes to mind. In fact, this question also contained images of the sinus, I think. So it was an image showing sinusitis and mention of recurrent respiratory infections with the chest X-ray showing the heart deviating towards the right, or maybe not right to say deviating. The heart was situated on the right of the midline. That would signify that the patient has situs inversus. Obviously, among these options, the best answer is cartilaginous syndrome. This is the only one which is associated with situs inversus. Young syndrome also has bronchiectasis, may have recurrent sinopulmonary infections, but no situs inversus. Cystic fibrosis produces bronchiectasis, no situs inversus. Produces pancreatic manifestations and other manifestations related to the intestine. DiGeorge syndrome, it's a thymic or it's an endodermal dysplasia. There's going to be multiple manifestations with regards to the thymus, with regards to the catch-22, right? So there can be cardiac defects like ventricular septal defect. Apart from thymic abnormalities, there's going to be cell-mediated immunity that is defective. Parathyroid, hypoparathyroidism because of endodermal dysplasia. But there's not going to be any situs inversus. So the answer to that question was cartilaginous syndrome. Next question, CKD patient has dyspnea and chest pain. What is the diagnosis? So options given by hyperphosphatemia. This does occur in CKD, but I think they had mentioned an ECG. So they had mentioned an ECG suggestive of tall T waves. So whenever you see tall T waves in ECG, it always signifies the patient has hyperkalemia. So the amplitude of the T wave correlates with the serum potassium levels. Whenever the potassium levels in the serum go up, the T wave amplitude also goes up. So tall T waves, hyperkalemia. When the potassium levels in the blood come down, the T wave amplitude comes down. It becomes flat and sometimes become inverted. So in hypokalemia, you get flattened T waves or T wave inversions. Hyperkalemia, you get tall T waves. Tall T waves with narrow base. Tall T waves, narrow base, hyperkalemia. Tall T waves with wide base, hyperacute T waves of myocardial infarction, also known as De Winter's T waves. Okay, so the ECG was mentioned showing suggestive of tall T waves. So you had to recognize which condition will produce tall T waves. That is hyperkalemia. Hyperphosphatemia leads to hypocalcemia because phosphate tends to bind to calcium, leading to hypocalcemia. So CKD patient can have hyperphosphatemia and hypocalcemia, but the manifestation on ECG of hypocalcemia is going to be QT prolongation. So prolonged QT would favor hypocalcemia. Likewise, Hypercalcemia leads to shortened QT, but in the ECG that was displayed for the exams, it was a tall T wave, which means the condition was hyperkalemia. Okay, so please remember, potassium based questions are always asked in entrance exams, whether it's NEET or INA. So always make sure you have revised potassium hypo and hyperkalemia based questions. Okay, next question was pan-SNR emphysema seen with deficiency of which enzyme? This is quite straightforward. I hope all of you got it right. The answer is alpha-1 antitrypsin deficiency. The other options are also not so confusing. Trypsin, chymotrypsin, elastase. No. So actually alpha-1 antitrypsin is what breaks down elastase, and when it is deficient, the elastase enzyme leads to both increased bronchial secretion leading to bronchiectasis also. So that's why alpha-1 antitrypsin deficiency patients can have bronchiectasis as well as leading to emphysema, and that emphysema is pan-SNR emphysema. So remember, smokers have centri-SNR emphysema. Pan-SNR emphysema is what is seen in alpha-1 antitrypsin deficiency. Okay, this is a quite straightforward question. A mother brought a 3-month-old child with nausea and malabsorption manifestations. She was asked to give gluten-free diet. This now I feel even general public, lay public can also answer this kind of a question, because gluten, the hype about gluten has been persistently increasing. So a lot of people are now aware of which food contains gluten, which does not. So all of them know about what is celiac sprue. So if an advice has been given to specifically avoid gluten-containing foods, that is barley, rye, oats, and wheat. So if this advice has been given, it's suspected probably that the patient has celiac sprue. Celiac sprue, which antibody? Some students said which autoantibody needs to be tested. So if that was the question, it's anti-TTG, anti-tissue transglutaminase. This is the autoantibody. Anti-gliadin antibody is also possible, but depending on what was actually asked. If it was what is the diagnosis, gluten-free diet, then it is celiac sprue. That I feel is too simple. Perhaps they have asked the antibodies which need to be tested, and that is anti-tissue transglutaminase or anti-gliadin antibodies. Okay, so this was one of the questions that was asked yesterday in session 2 or in shift 2. Yeah, so most common cause of death in IPF was asked. This was also a shift 2 question. Idiopathic pulmonary fibrosis. Now, idiopathic pulmonary fibrosis is a high mortality, untreated, up to 50% mortality in 3 years. So 3 years, if you diagnosed a symptomatic patient, this is a symptomatic patient, if you diagnose with IPF, in another 3 years, you may not see 50% chance that you may not see that patient anymore. Why does that happen? It's because of progressive lung disease leading to respiratory failure. So the answer to this question, most common cause of death in idiopathic pulmonary fibrosis, is progressive respiratory failure. Okay, so patients have chronic respiratory failure, which finally leads to them succumbing to IPF. Okay, now of course we have nintedanib and pirfenidone, which have mortality benefits. So patients with the idiopathic pulmonary fibrosis, nintedanib and pirfenidone, these can be started, and these have been shown to provide mortality benefits. Okay, so IPF no longer as bad. Most often what happens is they present too late. So by the time they develop symptoms and then seek medical attention, they already have very advanced disease. But now we know that a majority of these patients, IPF patients, will have a long-standing disease, but a long phase of asymptomatic period. They'll not have any symptoms despite the patient's lung having idiopathic pulmonary fibrosis. Anyway, this time what was asked was what is the most common cause of death in IPF, and the answer is progressive respiratory failure. ABG based questions every exam, so this has always been highlighted by us in the app. So this time what was asked was patient having a pH of 7.2, bicarbonate is very low, dangerously low. That means there is obviously this itself, you don't expect this kind of a response. How much of a respiratory alkalosis there is, you don't expect such drastic response, such drastic reduction in bicarbonate levels. Now the question will be, is there only metabolic acidosis or is there something else also? Is it a mixed acid-base disorder? That means if the patient has combined metabolic acidosis and respiratory alkalosis, that's a possibility, but isolated respiratory alkalosis is ruled out. PaCO2 is carbon dioxide partial pressures is 16 millimeters of mercury. Sodium seems normal, 136. Chloride is 114. Now the version which I got, there's only one option which mentioned metabolic acidosis, and therefore obviously that one becomes the correct answer. But if there were other options, all you had to do was first of all make out what the pH is. 7.2 means acidosis. Which direction has bicarbonate and carbon dioxide and bicarbonate gone in? Is it in the same direction as the pH. Now in this case, pH has reduced, the bicarbonate also has reduced. Remember, the normal bicarbonate is 24, normal pH is 7.35 to 7.45, and PaCO2 has also reduced because normal PaCO2 is 40 millimeters of mercury. So if all have gone in the same direction and the pH has reduced, that means it is a metabolic process. If all have gone in the same direction, it's a metabolic process. If the pH has reduced, then it is acidosis, which means it's a metabolic acidosis. So definitely metabolic acidosis is there. Now, in case if they had asked it in a little more complicated way, if they had asked whether it is metabolic acidosis or just plain metabolic acidosis with high anion gap, which obviously in this case, this is the answer. Anion gap here being the sodium minus combination of chloride plus bicarbonate, and in this particular case it will come out to be 36 minus 120, which is 16 mmHg. 16 mmHg is slightly increased. Up to 12 mmHg is the what can be considered as normal anion gap. Normal upper limit of anion gap is 12 mmHg. Since here it is 16, definitely there is high anion gap. Okay, but what they could have done is they could have asked, is it just plain metabolic acidosis with high anion gap, or is it metabolic acidosis with respiratory alkalosis? In which case you would have had to apply your minds and try and figure out, is the response of the bicarbonate proportionate to the drop in the carbon dioxide levels? So fortunately they have not done that. They have just asked directly, is the patient having metabolic acidosis? Answer is yes. So the answer to this question, high anion gap metabolic acidosis. Okay, please, it just highlights how important acid-base disorders are for all your entrance exams. Okay, 50-year-old man with hypertension, diabetes, sudden onset weakness on the right arm and leg. So right hemiparesis the patient has. There is left facial palsy and nystagmus on looking to the left. So what is the diagnosis? Okay, so if you analyze the question, the patient has hemiparesis on the right side and a gaze palsy towards the left side. So there's nystagmus on left gaze. They have not mentioned specifically that there is a impairment in one eye. So is it one eye or is it a gaze? That means both eyes. So if it is a single eye problem, then they should have mentioned, or at least they should have shown an image where there was a weakness of abducting that particular eye. Instead, they have just mentioned that there is nystagmus on left gaze. So nystagmus on left gaze means both eyes are probably not able to abduct, or rather they're not able to produce that conjugate movement. So on trying to look to the left lateral rectus is not working, and simultaneously even the right medial rectus is not working. So that kind of a gaze palsy would lead to nystagmus in both eyes. Okay, so if you can recollect whether both eyes are involved or only one eye was involved, that would help out. But judging by what information I have received, there was no mention of a unilateral eye abnormality. It was a bilateral nystagmus on left gaze, which means gaze palsy. So gaze palsy with, that means ipsilateral gaze palsy with the contralateral hemiparesis or hemiplegia would favor a diagnosis of Foville syndrome. I think even the seventh nerve was mentioned. There was a facial nerve palsy also. Ipsilateral gaze palsy and ipsilateral facial nerve palsy. Okay, yeah, so it is here. So left facial palsy along with ipsilateral gaze palsy and contralateral hemiparesis. So the person cannot look to the left. Facial nerve is paralyzed on the left, but the hemiparesis is on the right. So which means when there is crossed hemiplegia, you always suspect brainstem syndrome. All options contain brainstem lesions, but Benedict syndrome would have ended up being associated. It's a red nucleus lesion. So there will be tremors. There can be tremors. There can be chorea. So these are not mentioned in the scenario. Therefore, it's not the right answer. Lockton syndrome. It wouldn't have been hemiparesis. It would have been quadriparesis, which was not mentioned clearly. That's why that is also out of the question. It wouldn't have been just nystagmus, and it wouldn't have been just unilateral facial palsy. It would have been bilateral facial palsy. So that is ruled out. So only doubt is between Millard-Gubler and Foville. Millard-Gubler is a combination of 6th and 7th nerve nucleus lesion, whereas Foville syndrome is just a fascicular, or rather Millard-Gubler is because of a fascicular lesion, whereas Foville syndrome is because of a nuclear lesion. So because the nuclear lesion of the 6th nerve, I'm talking about 6th nerve, because the 6th nerve nucleus is lost, neither can the ipsilateral lateral rectus work, nor can the contralateral medial rectus, because the internuclear fibers are lost. The nucleus itself is lost. So there's nothing to fire and stimulate the internuclear fibers between the 6th and the 3rd nerve. Therefore, that conjugate movement itself will be lost. They'll have gaze palsy on the side of the lesion. So if this is what was mentioned, that there was gaze palsy on looking toward the left, or rather was nystagmus on looking towards the left with right side hemiparesis and left facial palsy. It favors a diagnosis of Foville syndrome, which is a nuclear lesion. Okay. Next question, 20-year-old without comorbidities underwent ECG, which revealed a PR interval of 0.21 seconds. So I think it was some health checkup. The person had gone for pre-employment health checkup, something like that. And the ECG, he was asymptomatic, did not have comorbidities, and the ECG showed a PR interval of 0.21 seconds. What is the diagnosis? Is it normal? Is there a first degree AV block? This is the only doubts, right? These two are ruled out because they have not even shown the ECG. I think even the ECG was not shown. So you can't make a diagnosis of second degree AV block or third degree AV block. Just in terms of a description which is limited like this without an ECG or without mentioning what's actually happening in the ECG findings. So if only this was mentioned, the doubt comes down to whether it is normal or whether it is first degree AV block. So remember, in Harrison, 0.2 seconds is the cutoff. Anything greater than 0.2 PR interval, anytime it is greater than 0.2, then it is considered abnormal. So 0.21 would qualify as first degree AV block. So the answer here is first degree AV block. Up to 0.2, PR interval is normal. 0.21 would count as first degree AV block. For second and third degree, it's best that we have ECGs to help us out. Okay. In second degree AV block, this is again subdivided into Movich type 1 and Movich type 2. Movich type 1 is Venki back, where the PR interval progressively elongates. Each successive PR interval keeps getting longer and longer, and finally there is an unconducted P wave. Whereas in Movich type 2, the PR remains fixed, but still there is an intermittently unconducted P wave. Third degree AV block, there is total AV dissociation. So here there was only a mention of PR interval being 0.21 seconds. It is abnormal according to Harrison, which says 0.2 is the cutoff. Okay. Next question, Alzheimer's disease. Highly expected questions on Alzheimer's disease. Fortunately, I hope you agree. This was a simple one. I couldn't get the last option. It was so simple that most students don't even remember all the options. We know that Alzheimer's disease, I think in the near future, the diagnostic criteria for Alzheimer's is going to get changed because it's all going to be based on markers like beta amyloid and tau. So you will be hearing it more and more. Maybe a year or a couple of years, it will change. Okay, how do you detect? These are considered biomarkers now. So they're biomarker based diagnosis for Alzheimer's, even Parkinson's. So that is going to come up in the near future. That's why this is a highly discussed topic, and therefore question based on this was anticipated. Fortunately, the question asked is not so difficult. I hope you agree. It is the accumulation of A beta amyloid, and it leads to amyloid plaques, extracellular or extraneural amyloid plaques. Intraneuronal, you will get neurofibrillary tangles. Then that is made up of hyperphosphorylated tau proteins. Okay, all these are biomarkers, more and more being used for studies, for research. Eventually, it will get applied even in clinical practice. Just a matter of time. Okay, so alpha-synuclein. This is something that is seen in Parkinson's disease. As I said, even Parkinson's will go in that direction very, very soon. Okay, the other options were not so clear, not important because we know it's quite straightforward. Next question, young man gives history of sudden cardiac death in the family. So family history of sudden cardiac death. If the diagnosis is HOCM, so they've already given a diagnosis of HOCM. I think there was another question where there was a gross specimen also of HOCM that will come under pathology. So HOCM is a favorite for NEET and INI, both. They keep asking about HOCM. So which of the following will increase the intensity of murmur is the question. So basically they're asking about dynamic auscultation. So in dynamic auscultation, how can you increase the intensity of the murmur in a patient with HOCM or MVP? Both the same principles apply. Whenever the chamber dimension, the left ventricular chamber dimension is less, the murmur intensity will increase. Anything that increases or distends the left ventricle, anytime the left ventricle chamber dimensions increase, the murmur intensity will come down. So options given are sustained hand grip, squatting, Valsalva, and bending forward. The only maneuver here which will reduce the dimensions of the left ventricle is Valsalva. On applying Valsalva maneuver, intrathoracic pressure will increase, the left ventricular outflow will, or rather the right-sided inflow will reduce, and that is why the left ventricular dimensions will reduce and the intensity of the murmur will increase. Okay, so dynamic auscultation both in MVP and in HOCM, the intensity of the murmur is increased with Valsalva because obstruction increases. It's a dynamic obstruction. Even the obstruction is dynamic, left ventricular outflow tract obstruction is dynamic, and the auscultation here is also dynamic. and therefore you expect the murmur intensity to increase during Valsalva. On sustained hand grip, after load increases, the left ventricular emptying reduces, left ventricle gets more distended, the murmur reduces. Squatting increases the preload, and there also increases the afterload. So therefore the left ventricle distends, the murmur reduces. Forward bending has similar, because the effect of gravity is lost, forward bending can increase the right ventricular inflow and therefore distend the ventricles, reducing the murmur. So these are the procedures by which you can reduce the murmur, but how you can increase the intensity of the murmur is asking the patient to breathe against a closed glottis or breathe forcefully against a closed glottis, that is Valsalva maneuver. Okay. Patient presented with hypotension, bradycardia, cardiac troponin level are negative. What is the diagnosis? So this is a slightly tricky question. Now remember, repeatedly in the app, I've discussed about what are the situations where you get both hypotension and bradycardia. So only a limited number of conditions. One is of course inferior wall MI. Otherwise you can get it in patients with OP poisoning also. So a combination of bradycardia and hypotension, you can get it in neurogenic shock. Okay, so this kind of a combination. Options mentioned were hypertrophy of smooth muscles. So actually it was more like a pathology based. Hypertrophy of smooth muscles, is that what's happening, leading to hypotension and bradycardia? Which smooth muscles are we talking about in that case? Okay, so none of these conditions have hypertrophy of smooth muscles. Fibrinoid necrosis, this is a feature of malignant hypertension. So malignant or hypertensive emergency, hypertensive emergency, there's going to be fibrinoid necrosis of the capillaries. So this situation does not seem to suggest any hypertension at all. Aortic wall being weakened, so which means an aneurysm. Is an aneurysm rupture? Is that what the option is suggesting? Aneurysm rupture. If so, in that case, you would have expected bradycardia. Anytime there is rather tachycardia, anytime that there is a loss of volume, hypovolemia, as a reflex should produce tachycardia. So you would have had baroreceptors getting activated because of hypotension, that would have led to tachycardia. That's what you would expect. You wouldn't expect hypertension bradycardia if there was weakening of the aortic valve. Fibrous cap rupture. So fibrous cap, what has fibrous cap? It is atherosclerotic plaque. So atherosclerotic plaques have fibrous cap. Is that what has ruptured and led to this situation? Now, if you consider that these did not fit, and this is the correct answer, the distractor here is cardiac troponin levels being negative. You expect that fibrous cap, if it ruptures, it produces a myocardial infarction, and it's an inferior wall myocardial infarction. It can lead to bradycardia. Temporary, it usually leads to AV nodal conduction delay, leading to temporary AV nodal block also, third degree AV block also, but it will be temporary. Hypotension is expected, especially if there is an extension into the right ventricle. The inferior wall MI with right ventricular extension, definitely hypotension can occur. Even otherwise, inferior wall MI can present with hypotension. All these would have fit well, except the fact that cardiac troponin is negative. If the mention was cardiac troponin levels are negative, maybe it is an early MI, early myocardial infarction. Remember, troponin levels go up only beyond 3 hours. So 2 to 3 hours it requires for it to start rising. Maybe the patient has presented before that. That would be one of the explanations, because these definitely do not fit. Okay, so the best choice among the recollected options seems to be a fibrous cap rupture. Maybe there is some deviation based on recall also. And final question that I'll be discussing is a 30-year-old pregnant lady with 8 weeks period of gestation. The TSH is low, but T3, T4 are elevated. That means the patient has hyperthyroidism. The patient has thyrotoxicosis, presuming that they have hyperthyroidism because all the options seem to mention anti-thyroid drugs. What is the best choice? You all know that although the drug of choice in Graves' disease or hyperthyroidism is methimazole, but in patients who are pregnant in the first trimester, always go for propyl thiouracil. So in the PTU has limited uses because it has a very short half-life. So PTU in hyperthyroidism is used especially when the lady becomes pregnant. So first trimester, switch from methimazole. Methimazole is teratogenic. Methimazole can produce aplasia cutis, and that is why it cannot be given in pregnant ladies during the first trimester. So first trimester, switch from PTU, or rather from methimazole to PTU, and continue it till the end of the first trimester. Second trimester onwards, you can switch back to methimazole, where the organogenesis has already been completed. Now, this was quite straightforward, PTU being the best choice. PTU, the other uses in patients with mixed edema coma, or rather with thyroid storm. So patients with thyroid storm, because PTU has a quicker action, you can give PTU instead of methimazole. But the problem with PTU is high dose PTU can end up leading to liver hepatotoxicity. That's why even otherwise we end up using methimazole only, even for thyroid storm patients. But in this particular question, the answer is straightforward, PTU. Potassium iodide you cannot give for hyperthyroidism for a long time. So you know that potassium can produce, or potassium iodide rather, can produce Wolff-Chaikoff effect, but that cannot be sustained for too long. Eventually, all the pent-up thyroid hormones can end up getting released, leading to worsening of the thyrotoxicosis. So you can't use potassium iodide for a long time. Right, so I just wanted to highlight that we've done this faculty connect. So a lot of times what you may end up having to face is you're reading so much. It's a lot of intense reading, a lot of volatile stuff you're reading, but you're not remembering. It's not so easy, and it's a marathon. So you read today does not mean you'll remember it in another 15-20 days, and your exams are months away. So what do? You can't simply read in the last minute. You're not going to remember anything. You have to read right from the beginning, no doubt. But there are times where you need to take a break. You're still you want to read something, but you're not in the receptive mood. Your mind needs a break. So you can always try and look at our Faculty Connect videos in the app. With Manipal Medes, we've made a lot of videos based on previous year's topics and expected important concepts, which has worked out. So this is a video that we put up in the Faculty Connect section of Manipal Medes app, where we've highlighted that the first trimester of pregnancy, propylthiouracil should not, or rather should be, the preferred drug, and methimazole should be discontinued. So just wanted to highlight that. Of course, this was actually a video based on emergency contraceptives, which is also a very important topic. So this is what we try to do, to try and make videos which are short videos but give a lot of yield in terms of previous year's questions as well as anticipated next questions, which you can watch in your free time when you don't want to totally relax and go away from studies also, but you don't want to do high intensity studies also. Okay, so with that, I'll conclude this recall session. As I said, there has been a lot of overlap and there's a lot of questions which perhaps you feel I have not discussed. Yes, that's correct, because probably those will have a pharmacology basis or a radiology basis, and those you can catch in sessions by Arpit sir and by Abhishek sir and so on. So even microbiology based, tuberculosis based questions, Meenakshi sir will be discussing that in microbiology. Okay, so with that, I'll conclude this session, and all the best to all the students who appeared for the exam yesterday. I hope you get the seats that is worthy of your preparation and the hard work that you put in. And with that, I'll conclude this session. Thank you very much for watching.